Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences, different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is an honorable guest from the USA, Professor Aitan Ras. Professor Ras is the associate professor at the NYU Langone Medical Center in Interventional and Diagnostic Neuroradiology, New York, USA. He is a neurointerventional radiologist working at a high-volume urban academic center in multidisciplinary team. He has a large experience with complex neurovascular conditions, including brain aneurysms and brain AVM, dural AV fistula, stroke, and carotid disease. He is a passionate teacher and mentors through his famous online intervention radiology platform, neuroangio.org, and other multiple educational websites. We are extremely honored to have him today at our webinars, and today he'll be talking about the Dyna effect, the role of high ultrasound imaging in the AngioSuite. The speaker for the second session of today is our honored guest, also from the USA, Dr. Carolina Benjamin. She is an assistant professor at the University of Miami and Jackson Memorial Hospital Systems, Miami, Florida. She is also director of the Resident Education Department of Neurosurgery, University of Miami, Florida, and the director of Center for Advanced Radiosurgery at the Sylvester Cancer Center. She has several awards and honors for her outstanding contribution to teaching in neurosurgery. We are extremely honored to have her today at our webinars, and today she'll be talking about role of radiosurgery in the complex AVMs. The chair for the first session of today is our distinguished faculty from Japan, Professor Naoto Kimura. He is the director of Department of Neurosurgery at the Iwate Prefectural Central Hospital, Japan. He is a member of Japanese Board of Neuroendovascular Therapy and Stroke, and he is an integral part of the ACNS online as well as offline educational activities. We are extremely grateful to him for accepting our invitation to chair the session of Professor Aitan Ras. The chair for the second session of today's webinar is our honored guest from Malaysia, Professor Chipinchi. He is a senior consultant neurosurgeon at the Gleneagles Hospital, Kuala Lumpur, Beacon Specialist Hospital, and Pantai Hospital, Kuala Lumpur. He is a pioneer in stereotactic radiosurgery and DBS in Malaysia. He was the past president of the Neurosurgical Association of Malaysia and the president of the 8th Asian Congress of Neurological Surgeons meeting. He is also a noted author who has published more than 40 articles in regional and international journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Benjamin. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Naoto Kimura.
Okay, thank you very much. Good afternoon, everybody. I'm Naoto Kimura from Japan. It's 9:30 in Japan. So first topics is about the Dyna effect, about the role of the ultra high resolution imaging in the AngioSuite. So the AngioSuite is the first step of doing the endovascular therapy. So this is very important part, I think. So we're going to have some lecture from the Professor Aitan Ras. Is it right? And about the AngioSuite. Okay, can you please start your session?
Yes, sure. Thank you for having me. Thank you for the invitation. Do you see the screen? It seems you do. And it's a pleasure for me to talk about imaging in the AngioSuite, which is a topic I'm very passionate about, as you said. These are conflict of interest or disclosures. Mostly, like most important, probably like Siemens and maybe some off-label use of certain devices. This is part of my team, Max Shapiro, Aris Nosek. These are our accounts on Twitter where we do some educational work. And this is the website founded by Max Shapiro, where we put a lot of the work that we do. I train with Kim Nelson, who is the inventor of the neuroform and pipeline embolization device, and this is the rest of the team, as I discussed. The outline of the talk is really talking about the lessons that we learn from high-resolution vascular imaging, and these are lessons that can be applied in a lot of different diseases. And I'll see how much I can go through as much as possible in this. I believe is 40 minutes, and I'll probably have to skip through some for a purpose of time. So just going back into the history of the imaging in the neuroangiosuite, you know, we're all aware that angiography started in 1927, and this is the first images from angiography and from monits. And the next The next really like evolution in technology, like important evolution, was the development of the digital angiography. So as you see before, no subtraction, the subtraction from the of the bone. The subtraction made really like the possibility of the diagnostic imaging better. Now, what's the evolution after that? The development of the rotational angiography. So the people realized that rotating the machine during the injection would allow a better 3D understanding of the aneurysm. That was then improved with softwares in the late 90s. Then after that, the main improvement was the development of flat panels, which is just a technology improvement that made easier like to rotate the machine around the body because of the flat panels are much lighter and can be rotated faster. So we started to get better 3D imaging. Then after that, it was just evolution of software, software that allowed to perform 4D imaging, fusion of imaging that would allow to do all certain different things. So really, like in 100 years, we went from this to this, and that's what I will talk about. What can we accomplish today with imaging? So when we talk about the terms that we use as neurointerventionists, we use the term like the 3D DSA, which is a Siemens term, but it's essentially the classic 3D acquisition. The machine is rotated around the head twice, one mask followed by a contrast. And this is the kind of imaging that is obtained. It's the very classic sort of like aneurysm angiography evaluation to look at the 3D, what we classically call the 3D. There's also a higher resolution imaging that all the vendors provide, Siemens, Philips, and so forth, the GE and so forth, which is a higher resolution imaging that is called cone beam CT. Now, this is a rotation, a single volume without the mask usually, over a longer period of time. And this kind of imaging is routinely used to look at the post-stenting, post-flow diversion, post-web, and usually with diluted contrast to obtain an imaging that would let understand if the stent is very well opposed and so forth. Now, this particular protocol has much higher resolution than this one. The reason are a few, but essentially these are short. The machine rotates slower, so there's more radiation and more obviously more information obtained with it. So the concept that we realize, meaning interventionists realize, is that by applying this protocol, we could have obtained very good details of the vessels as well. So we could obtain essentially this kind of imaging that, as you see here, this is a basilar tip, and you can see, like, you can count the perforator, you can see the vessels extremely well. So how to obtain this kind of imaging? Essentially, you have to use the longer protocol, use a smaller field of view when you obtain your 3D, and inject correctly, and reconstruct and reformat correctly. So there is indeed in all these machines, and to obtain these images, you don't need like a machine, an ultra new machine, last generation even. Actually, this is from an older generation machine. But this option is available in all, essentially in all our machine. And one of the concepts is that, if you look at these are traditional 3D DSA image, and you see some details of this aneurysm, you can tell what's going on. Then if you do this sort of like longer protocol, what we call it the cone beam CT, you start seeing that there is more details that is visible, but it's not absolutely different. The difference is relatively small. But when you do the reconstruction and the reformat on this particular sequence, and you do it correctly, this is the kind of detail that you can get. And this is like a reconstruction of this particular protocol. And now you start seeing a lot of things. Yes, you see the aneurysm, but you see the choroidal coming from, you see also there are other perforator coming from it. You can really like see a lot of details more. So that's what I will talk about. I will talk about how using this imaging can lead us to understand things more. So let's start with aneurysm, for example, and let's start from that case that I showed you just now. Okay. Now, working on this image and doing like a rotational, we can get these two particular image here, and now we can look at the aneurysm much better. We see the anterior choroidal coming from there. We see another perforator coming from the dome of the aneurysm itself. Then we see another actually perforator coming from the distal neck, okay? And then we see that the aneurysm has indeed like 3 little bubbles on top of it, okay? So we much better understanding of this aneurysm. Now, this is imaging that was done after the treatment. This was a ruptured anterior choroidal artery aneurysm coming from coiling. And, I saw this image and, I coiled the aneurysm, and I coiled without being too aggressive, meaning that there was a stage, the second stage plan with a flow diverter here, but I put enough coil to secure the aneurysm. And what I didn't notice immediately is that indeed, just by putting the coil, there was okay, the choroidal artery, I kept it open, and that was very important. That was the thing that I was really careful about. But without realizing that there was a perforator coming from the dome, I did coil the dome, and you see there the perforator retrospectively, and you don't see it here anymore. So by coiling the dome, I did close indeed this perforator, something that then I proved by doing an MRI and showing this little infarct in the base of the basal ganglia. So this is a demonstration how this imaging demonstrate a perforator coming from the dome that otherwise would have been very, very hard to notice. So when we talk about aneurysm, the role of high resolution imaging is really to understand the features more. If you see this aneurysm of the pericallosal, you did this sort of imaging, look at how much more details you get of the aneurysm shape, of the aneurysm morphology. Is there perforator? Are there perforators from the dome or around the aneurysm? Is there an extra small aneurysm? And those are information that eventually can change the approach, because if I show you this patient, with a 2 millimeter A1 and 4 millimeter MCA aneurysm, right? We can argue, do we need to do anything? What do we need to do? Probably just observe, right? Unruptured, right? Now, if I do the high resolution imaging on these particular aneurysms, okay, and I show you this is the MCA, right? And we start looking at this MCA, and we recognize indeed presence of little bubbles that come from it, and relatively irregularity of the wall, or this A1 aneurysm that, yes, is very small, but which would be this one, very small aneurysm, but again, quite very irregular. Maybe some of us would change their mind about, do we need to do anything or not? Other examples. Patient come in with a little cortical subarachnoid hemorrhage, very focal. Is there a mycotic aneurysm? Yes or no? Patient has endocarditis, and we do an angiogram. And do an angiogram, try do a 2D angiography, try to understand. Well, really, there's nothing obvious that show up on the 2D. Then we do this sort of imaging. And this is the kind of resolution that we get now. By spending quite some time looking at the images and focusing in the area of the hemorrhage, now you start seeing that there is something there, right? There is a little fusiform aneurysm, likely mycotic because of the history, and this is the ruptured aneurysm. Now, retrospectively, if you look at the 2D, the aneurysm is there, but it's just extremely hard to see. Other example, patient with subarachnoid hemorrhage, mostly in the posterior fossa, but also extending superiorly, rupture dissecting right vertebral artery aneurysm, and with decent size contralateral vertebral artery. So what to do here? Sacrifice is absolutely an option, and because of the contralateral decent size vert. So we decide to do anyway, the higher resolution imaging. Here you see a pica coming from here. And what we learn from that, we learn that yes, there is a pica. Then you see here the pica origin. There is an anterior spinal artery that we can see here, okay. But there is also another little branch that comes just past the aneurysm here, and this is it would be like a cortical sort of cerebellar branch. So now when we decide to sacrifice, okay, yes, we will sacrifice, but we will be careful not to close this branch that otherwise, just by looking at it 2D, we may absolutely not understand in the same way. So that's what we do. We sacrifice, and this is post, the pica is spared, the anterior spinal artery is spared, but also that cerebellar branch past the aneurysm coiling was spared. Other example, very, very irregular ruptured ACOM aneurysm in a patient with a contralateral ICA occlusion. And patient has a rupture, needs treatment. What to do here? You obviously have to spare the ACOM because it's a contralateral occlusion. So this A1 actually helps the MCA. Try to understand with a 3D. very hard to understand with a 3D exactly what's going on. Yes, obviously there's an aneurysm, seems bilobed, there's an ACOM. And this is the role of this sort of imaging. You can get much more detail by applying this protocol. Look at the difference between the resolution of the traditional 3D versus the resolution of the cone beam CT angiography with very good injection. And this is a volume, a rotated volume of that shows shows that there is actually like a fenestrated ACOM here and another fenestration here. And this is just a scheme of this particular aneurysm, very, very hard to understand otherwise. So how to treat this kind of imaging told us that we can actually put two webs, stack one on top of each other, and that's what we did with a very good result. But bottom line is that this is an example where the cone beam CT imaging led to a better understanding anatomically of what we exactly were dealing with. Other example, like subarachnoid hemorrhage in the posterior fossa, you do 2D imaging, really like nothing really shows up. What's exactly ruptured here? Really looks like an aneurysmal subarachnoid hemorrhage. And that there it is, like by looking better at the highest possible resolution image, you see this little perforator like aneurysm coming from the back of the basilar artery. Other roles, generally speaking, like more understanding, right? You know, these are classic hypophyseal, superior hypophyseal aneurysm. We all would call this that way, right? Projecting medially, just like in the supraclinoid segment, projecting medially, that's a superior hypophyseal artery aneurysm. That's how we call it. But why we call it like that? We call it like that because we know that a superior hypophyseal artery should come from it, but we never are able like to see that, except when we do this imaging. And there it is an example showing the superior hypophyseal artery coming from it. This is an example of many. Like it's a regular result that for superior hypophyseal artery aneurysm, when you do this imaging, you do see the superior hypophyseal artery coming from it. Moving forward with what's the role for fistula? You know, like this is an example of an acquisition in a patient with a sigmoid fistula, and really like you can, as you see here, you can really like see the hole, see the branches, follow the branches, see the holes between the arcades and the sinus as well. Sometimes the hole is one, sometimes the holes are multiples, and this is another example, sorry, the same example, but showing also the 2D associated with it. With the 2D image, it's really hard to say exactly where is the hole, what exactly is going on. While when you look at the cone beam CT imaging, you recognize very well that this is the sinus, and this is the arterial arcade with the hole being exactly in this particular spot. And you see actually the change of density when the blood comes, the contrast comes from the arcade to the sinus. So how is this useful? How is this useful in fistula understanding this? It's useful because you can then develop different sort of strategies to attack the fistula. For example, in this case, it's very hard to say, what are we going to do here? Going from this occipital, going from here, we have to spare the sinus. While when you do this sort of imaging, you understand that you can actually access the hole from the vein and get to it from the vein in what we call it a super selective transvenous embolization. So coming from the vein, going inside here, and then embolize from there. And then this is before, and this is after, complete resolution of the fistula just with a minimal invasive, very focused, super selective transvenous embolization. This is another patient with a fistula. In this case, it's a cavernous fistula, and it's a high-grade cavernous dural AV fistula with supply, ipsilateral supply with drainage to the right cortical vein. This is the injection from the contralateral ascending pharyngeal, showing selectively the drainage to the right cortical vein. So what to do here? We do this. We do the Dyna CT. And look at the details. You can follow a single vessel supplying the fistula, and you recognize the fistula is really in the back of the cavernous sinus, okay, which is in this location. That's why there was the flow void here. And this is the 3D reconstruction of the of this Dyna CT. And again, look at the details that you can get. It's a beautiful image, but looking at the cross-sectional acquisition of this, you can get data that is useful for your intervention, which is, in this case, the recognition that indeed there is a little inferior petrosal sinus that get to that. And this inferior petrosal sinus is gonna be able to use as a route. So even if initially the angiogram didn't show any outflow to the inferior petrosal sinus, we know from this DynaCT that there is a space to that, so we can try to access blindly, even if we don't see that obviously on the 2D. And this is the access to it from the inferior petrosal sinus. We get to that, and we coil it, and we cure this fistula with again with a safe transvenous approach. In other examples, same disease, same location. We have this dural fistula of the posterior cavernous sinus on the right, and this is the angiography. Again, no outflow to the inferior petrosal sinus. There's outflow only to the cortical vein and a little to the superior ophthalmic vein. So how to access this fistula? We try to avoid transarterial. So transvenous, there's no good route really, except that when you do the DynaCT and you study the image and you look at the image in detail, you appreciate something very interesting here, because this is the outflow of the fistula that goes back here and then goes anteriorly toward the lateral cavernous sinus. But looking at it in detail, you see there is this sort of like appearance that there seems to be a cutoff here, which would be a cutoff in the region of the superior petrosal sinus. You see here, you see it here. And this sort of cutoff that you appreciate in all three planes suggests that this is a relatively new thrombosis of what can be actually a route of the fistula. So having said that, let's try to go through very gently and see if we can indeed go through this. And this is an image that shows the more lateral part of the superior petrosal sinus. So this is going to be our access from the from the jugular vein going up here and going medially. And then we're going to try to go through this sort of like blinded segment and maybe get to the fistula. And we did that, and very gently, very gently, actually the wire went through, and that's it, how we get to the posterior part of the fistula. And indeed, we were able to coil the fistula, close it off, and cure this fistula with a safe transvenous embolization, thanks to the images that were provided by the DynaCT. I'll skip on this other fistula for interest of time, so I can show you other applications for other disease and other sort of imaging, which is this. This is another disease, right? It's a carotid cavernous fistula, traumatic, right ICA injection. You see like, essentially you see like the ICA, and then you see there's no filling of the brain, and actually there's filling of the contralateral veins due to a fistula in the right side. When you inject the left side, you see filling of the whole brain, and actually retrograde supply, minimal supply of the fistula. By mixing two separate 3D images, you can obtain this sort of like very beautiful image, which is an example of a AV3D DSA, which is something that we use mostly for representing the arteries and the vein in the same image. Something that has proved to be useful in certain selective case when the surgeon needs to know the relationship between the artery and the vein. For example, in this case of an ICA terminus aneurysm, in which the presence of the vein just close to the aneurysm proved to be a useful thing for the surgeon. This is another example. These are beautiful sort of imaging that can have a lot of really like role also in teaching and understanding the relationship between arteries and veins. And going back to our case, applying these, this is the cross-sectional image of the 3D imaging. And as you see here, you see like the right cavernous sinus, you see the internal carotid artery, and here it is the vein already. So you understand now that the hole is actually this one. Okay, so this is going to be very hard to treat just with the coil here, meaning you need certainly a balloon because the coil can certainly expel and so forth. The other interesting thing from this image is like looking at the negative image of the contralateral cavernous sinus, whereas you see actually like the nerves going through and so forth. And if you reconstruct this image, you can get some very beautiful anatomic representation of the cavernous sinus, where you see really like the carotid, you see the nerve, you see the trigeminal nerve, like the sixth nerve, and so forth. Moving forward, let's talk a little about AVMs. And I'm going to talk about the role of AVM by showing, for example, this case of a posterior fossa cerebellar AVM. You see here on this 2D, like the early venous drainage in this precentral vein, doing the looking at the image like this is not going to be too helpful. This is like the what come out essentially of the acquisition. What you need to do is really the reconstruction. And here we're going to do a very small reconstruction of this area here. And that's the kind of imaging that we get. So now, as you see, like now we're talking about much higher resolution, and we can understand it much more. Now, going back to the 2D, you know, the 2D imaging are going to be very important to understand the dynamic of the flow. This is an early image. This is a late phase. On the 3D or cone beam CT, we're not going to get this sort of like dynamic sort of sense of what feels in which phase, but we're going to have a very good anatomic representation. So this is the AVM, okay? This is the AVM, which would be around here, okay? And this is the initial outflow of the AVM, which is this initial little stump of the vein, okay? Then from here, the vein will go to two directions. We'll go to the precentral vein, but also retrograded through this sort of like superficial cerebellar vein, okay? And now what you notice on this anatomic image, there's actually another two veins, right? There's 1 and 2, which are veins, they're brainstem veins that drain in the same spot. So now we know from this anatomic representation, we know that actually to treat this fistula safely, we should probably be able to close the vein only up to here, because we need to preserve the outflow of the vein. Now we go back to the 2D, okay? And we try to understand these things. Now on the 2D, we see the outflow to the precentral vein, to the superior cerebellar vein. Now on the later phase, what we see is actually those two brainstem veins that drains toward that direction. And we see them, they're not outflow of the fistula, but instead they're outflow of the normal brainstem. Okay, so by combine the analysis of the 3D and the 2D imaging, we can really have a very good understanding that this is an AVM that needs to go to surgery, because only the surgeon will be able to selectively and precisely close the AVM and preserve these brainstem veins. Another example of a hemorrhage in the brainstem from a fistula, from an AVM. Sorry, you do the 2D imaging, you certainly see an aneurysm. But you know how to get much more detail of that. Who's supplying this? How to get there, right? And this is the role of higher resolution possible imaging, which is the cone beam CT. You see the aneurysm well, but now playing with the 3D, like with the volume rendering, you can really understand the route to that. And specifically, you see that there is a collicular branch coming from here. This is going to be our route, and we can go with a microcatheter as close as possible to the aneurysm and embolize, in this case with glue. And you see the glue now after, in the post-op CT, the glue filling the aneurysm without any residual actually AVM. This glue injection actually cured this particular patient. Moving forward, I'm going to talk about the application for, generally speaking, vasculopathy, what I call a vasculopathy, moya-moya, dissection, ICAD. And we know very well from Asian countries, actually, studies the anatomy of moya-moya, some excellent papers out there. And you know, we know that moya-moya collaterals can be different way, and this imaging has a very good role to understanding the collaterals in moya-moya. For example, a collateral that is very often there is this one between the ethmoidal arteries and the anterior cerebral artery, what is called like the rete. The rete ethmoidalis, and here is an example of this connection between the ophthalmic artery and the anterior cerebral artery, and that's I'm going to show you more in details. This is from a paper in which they describe this sort of like anastomotic connection between the ophthalmic artery and the anterior cerebral artery. And this is what we can understand from a DynaCT in a patient with moya-moya. And when you go through and scroll through these, you're going to see here an ophthalmic artery, and you see how from the ethmoidal artery here, like there is this connection that connect with the anterior cerebral artery, and here it is. And you can study this, and you can look at it in different directions. Here it is the anterior ethmoidal artery that then connects with the anterior cerebral artery, and here it is the same way. Also, the posterior ethmoidal artery was helping here. In hemorrhagic moya-moya, under this imaging that certainly can help in understanding what's the source of a hemorrhage, And when you do the 2D, it's very hard to pinpoint exactly to what's the cause of the hemorrhage. While when you play with your 3D imaging, you can really find that indeed in this case there was an aneurysm, thalamic aneurysm in a thalamoperforator, and then you can selectively go and try to treat that particular aneurysm. And a very important role in our experience of this imaging has been for dissections, and intracranial dissection, specifically MCA dissection, that can be very hard to diagnose. And indeed, in our opinion, they're actually underdiagnosed. Why? Because if they cause an acute occlusion, it's very hard to differentiate intraluminal clot from a clot caused by a dissection. And also sometimes another problem is that sometimes when you reopen a vessel and you see a dissection, you're wondering if you're the one that caused the dissection by trying to reopen the vessel, while indeed often it could be that the dissection was already underlying and the cause of the clot. Generally speaking, as interventionists, when the vessel open and then reclose, this is something we have to think about it. And again, cone beam CT, very important. Let me show you an example. It shows a very, very good application of this. You see this is a patient with a stroke. You see the hypoperfusion of the MCA here. You see some sort of stenosis, but it's hard to really say what's going on in this patient. And now you do a cone beam CT, you look better at this area, and that's what it comes without touching this. So there's no question. This is absolutely spontaneous. And you look at this vessel, you look at how there is a double lumen here, a blind pouch of the MCA. This is an MCA bifurcation, blind pouch. And actually, it's this hematoma in the wall of the vessel that compresses on the inferior division here that causes the stenosis and the reduced flow. So there's no vessel occlusion here, actually, is the stenosis caused by hematoma that causes the delay. Other example, patient with a left-sided hypoperfusion, you do a CTA. Certainly the vessel is irregular, but it's hard to really call this a dissection. It could be many other things. You go for an angiogram, and I mean, the vessel looks very, very narrow extensively, but bringing patient, and we ended up not doing anything because we thought it was very dangerous at this point to touch this. Brought the patient back 1 week later, and there it is. There is what we show. We show that there is a pseudoaneurysm surrounding this vessel, something that we didn't touch. So obviously this was the result of a dissection, and something that you can also pick up on imaging, like on the gradient echo. Here you see the hematoma along the wall. On the T1, when you look at the vessel magnified, here you see the intramural hematoma along the wall of the MCA. And interestingly, we bring up the patient one year later, and the vessel more or less came back to normal. Okay, not normal, but closer to normal. And we repeat the Dyna CT. And now what we see is we really see what a chronic dissection would look like, right? That pseudoaneurysm more or less resolved, but there is certainly left sequela. And this is how it looks like at 1 year. And what came very interesting about this case is that there is now good feeling, but the good feeling seems to be mostly from a false lumen that fills the MCA distally, while the true lumen seem to be this small thing that remain very small. Now, interestingly, for this patient, we found a CTA that was done before all the event, around 2 months before the first event. So we have a very good sense of how her vessels were looking when she was normal. And this is the CTA done before the dissection happened. And this is now in the chronic stage after the dissection. And here now you see this bifurcation, and there you see the bifurcation. You can really follow how this is indeed the true lumen, and this is the false lumen filling this this MCA. So we described the role of this of cone beam CT for dissection, which I think is very important. I will for ICAD, I want to show you some example, one example specifically, because it can be important to understand where are the perforators coming from, what kind of collaterals are present. This is an example of a patient with a chronic left IC occlusion, but also with right-sided hypoperfusion. You see these infarcts here on the right side, like this delay filling in the right MCA territory. You do an MRI. She has indeed acute infarcts here. This is not the first episode, so we consider doing for stenting. And this is the angiography. What it shows this severe stenosis of the supraclavicular ICA, and this is certainly the problem for her. Now, there are some sort of interesting vessels around, okay, And what are they? What do they represent? And these are this cross-sectional imaging from a Dyna CT, and you can follow this vessel, and you see how this vessel go up toward in the midline, toward the hypothalamus, and then join the anterior cerebral artery. And you see them here on the coronal plane going medially through the hypothalamus to the anterior cerebral artery. And so these are very interesting example of collaterals between essentially the superior epiphyseal artery through the pituitary branches of the using essentially the hypophyseal portal connection toward the hypothalamus, and then from there joining the ACA through the perforator coming from the ACA toward the hypothalamus. Anyway, we're going to stent this patient, and this is the post-stent. Very good result. Remember how it was. Now look at this much better filling. And you can look at the images post-stent as well, very well. And by applying certain particular protocol, you can really maximize the visualization of the stent and the vessel. This is another patient, by the way, just to show you like the application of this imaging. Going to finish, I want to show you also an application for spine. Has different roles in spine. I'll skip on this example. This is an example of an epidural fistula, and became essentially standard for us to do this imaging in spinal fistulas, because it really gives you a much better understanding of the anatomy, and in order to do effective but also safe embolizations, and tells you like the route, how to get there, where are the supplier to the anterior spinal that come from the same spot, and a very important role. This is in this example of an epidural fistula. This shows the MBCA cast in that specific region, or this other example that is very, very peculiar to show what the concept I'm expressing to you. You see this classic appearance of a fistula with this edema within the spinal cord, vessels surrounding the spinal cord. And you do an angiography, you see that actually left T8 is supplying the fistula, and here you see the vein going down, but it's also the same level supplies also the anterior spinal artery. Okay, so anterior spinal artery is also supplied by a left T12 segmental branch. So, but there's certainly supplier from T8, which is the level of the fistula. So now what to do? One obvious answer would be go to surgery. So the surgeon would be able to close the fistula without touching anterior spinal artery. And that's absolutely a good option, except that there are situations where surgery may not be ideal for patient-specific reasons. So that's where this sort of like understanding exactly where are these branches coming from may actually open an endovascular possibility. Because here, when you look at the cross-sectional images, you understand that actually the branches that supply the fistula and the anterior spinal artery are actually two separate branches. Two separate branches, they're not coming together. So this is schematized here. You have a branch that from the segmental goes and supplies the anterior spinal artery, and a separate branch that with a decent level of safety, or margin of safety, supplies the fistula. So looking and understanding and studies this imaging open up the possibility of an endovascular approach. And that's what we did. We went selectively into that branch supplying the fistula, and we closed the fistula, and we spare the anterior spinal artery. And this is an example that we published, and this is a very, very good case to show really how the application of this image can change the approach to that particular case. Now, we also apply this imaging to understand better certain diseases, such as the subdural hematoma, by doing a lot of mesomeningeal artery embolization these days. We actually try to study this a little better, and I'll skip a little through it. But essentially, we could understand and go back to the original anatomical description of the how the subdural hematoma develops, and show that in vivo, and get excellent images that show in vivo, like exactly like the filling of the membrane. And this is probably the best image that we obtained. This is a cinematic rendering of a Dyna CT that showed really like the filling of the membranes of the subdural hematoma with the recurrent bleeding. And another application that I wanted to talk about, I'll skip to this, is the application in the anatomy of the globe. This is a cadaveric specimen from Dr. Moret, and of a globe, and you see here the very, very interesting, beautiful anatomy of the vessels supplying the globe, the ciliary vessels, and the central retinal artery. Now, the good thing is that now we can obtain very similar imaging by applying this sort of cone beam CT resolution, and this is a 3D image obtained from that. It requires a lot of post-processing, but we can get to this image, and when you see here, there it is. Sorry, there it is. When you look at these images, this reconstruction, you can see the central retinal artery, you can see the ciliary vessels, you can see the papilla, and then you can create a volume rendering and look at it in 3D. Look at this, for example, the central retinal artery dividing the upper and the inferior branch, or again, like other examples of the volume rendering of these vessels that you can then rotate around and look very, very much as that. There's no higher possible resolution that you can obtain with any other imaging in medicine, the current medicine, of the vessels of the posterior to the globe. There's no MRA nor CTA that is able to show vessels in this particular way. Just another example of the same. So to finish up, and we published this experience last year, showing really like the role of cone beam CT to visualize the central retinal artery. Something that can open up clinical roles, like, for example, like what can this be useful for? It's to be defined, but certainly this is what we can get with this kind of imaging today. So to conclude, this sort of imaging has innumerable roles in the modern practice. And generally speaking, we cannot understand what we cannot see. The more we see, the more we understand. And these techniques allow us to understand more. Application in aneurysm, fistula, AVM, every single disease, honestly, in my practice, have found this technique have found a role to better understand. Limitations, more radiation, more contrast, and time consuming. Getting this imaging is not something that come out of the machine automatically. It requires some work. I invite you all to the banana course that we will have in next one in 2024. It's a neurovascular anatomy course that we hold here at NYU through neuroangio.org. And thank you very much for listening to me. And it's a pleasure for me to take any question.
Okay, thank you very much for your nice presentation, nice pictures, and your nice image-based strategy for your treatment. And I have very many questions, but first we have two questions from the audience. The first one is Dr. Harshad Parth. What you offer treatment for dissection of artery?
Okay, so you're talking about I showed two examples of dissection, of MCA dissection. We actually the patient needed more flow, and we tried first to raise the pressure, and that was actually enough for the patient to be okay. So we didn't need to stent nor to bypass the patient. So we didn't do any sort of treatment, meaning mechanical or surgical treatment.
Another question from the same doctor. The angiography called AVM cryptics is seen by this technique?
Yeah, I mean, absolutely. Whenever there has been examples in which, that I didn't show in this presentation, where a not understood cause of hemorrhage was really clarified by the use of cone beam CT. One of the locations where that is most useful is really the posterior fossa, the brainstem, the cerebellum, where, on the 2D angiography, that's an area that is hard to study because there's a lot of vessels overlapping. So by getting the cone beam CT and looking at the cross-section, not only the volumetric, but the cross-sectional, can really be eye-opening in certain situations of hemorrhage.
Thank you. And I have one very simple question. Your first case for the IC anterocoroidal artery, if you know that good quality, if you get a very good quality beforehand your operation, did you do the coiling at that case?
So that's a very good question. I'm glad I didn't see that, so I didn't have to think about it. I have to say, I probably would have not, and maybe the patient would have re-rupture, and maybe the outcome would have been worse. It's interesting, but it's an interesting kind of different perspective. Like, essentially, another way to look philosophically as your question is knowing, is it possible, and knowing and understanding more would lead us to make the wrong decisions. I guess it's possible, right? It's possible, and we have to be aware of that, and we have to be very careful.
I'm very agree to you that because the good resolution DSA will make the procedure very safe. This is the truth.
Yes.
Yeah.
Yes. No question. And it's I would say the doing this imaging is very important to keep in mind as a possibility. Okay, it's not mandatory, but it's important to keep in mind as a possibility in the back of the mind for situation where this is useful. Okay, and another important thing to say is that this imaging that all of us with an average machine, can do. This is any machine that was put in place within the last 10 years, would be able to do that. This is not something that is possible to do only with the last generation machine available. Okay, so that's another important thing to say.
I was very impressed. You're using the icon of Z, Artist Z.
No, the images that I show here are from Artist Q, which is again not the last generation Siemens.
Now we have Icono.
Okay, so Icono is the newer generation. Okay, so if anything, and we just got it like 2 months ago, and we started working with it, so with the Icono, there should be possibility to get even better. Okay, so what I showed is with the Artist Q.
Yeah, even for the Artist Q, you can get a very good, nice image. Even for the Artist Q.
Everything I showed is Artist Q.
This is very nice, I think. Yeah, thank you very much, and it's time to close our session. Thank you very much.
Thank you very much. Thank you. It was a pleasure.
Well, thank you very much. If there are any questions from other panelists, we can invite them. My co-host, Dr. Liu Bun Sen, would you like to ask something?
Yeah, thanks, Fajar. Thanks, Prof. for a very nice presentation. I probably have 2 questions, Professor. With so high resolution of Conbin CT, would you be able to tell us what case would need a digital subtraction angiogram, and which one would be enough by doing a Conbin CT? My second question, Professor.
Hold on. Can you repeat the question, please?
The first question is now, when do we need to do a DSA? Since you have very high resolution of a Conbin CT where you can see all the perforators. My second question, Professor. Now, do you have any study to compare that by high resolution Conbin CT and compare to intraoperative imaging? So, do we have any miss perforator in your image? Thank you, Professor.
Okay, very good questions. First question, the role of the DSA, 2D DSA, is absolutely important because that provides the sort of like generical, anatomical representation plus the dynamic of the flow. Okay, so the dynamic of the flow is something that so far, there's no substitute. Okay, so absolute complete role of the 2D DSA. Second question, I like it very much, and I'm waiting for the case that I get this imaging. I show the perforator and then go to surgery, and I ask the surgeon to count and tell me what perforator they see. I'm waiting for the case because I think honestly that we got to a level of resolution that is comparable to the level of the microscope resolution. So I would be surprised if the surgeon can show me a perforator that I'm not able to look on my Conbin CT, but I don't have a proof yet.
Thank you very much, Professor.
Thank you.
Well, that was interesting. Well, if there are no further questions, we can call it a day for the first session. And I would like to thank both the speaker and chair, Professor Eitan Raz, as well as Professor Kimura, for this wonderful session. I would like to mention to our viewers that this is being broadcasted on WeChat, YouTube, and Zoom, and altogether we have around 430 people who have joined us live. for this webinar. So we are extremely grateful to Professor Shubin for broadcasting this on the WeChat channel as well. So we'll move on to the second session. I would like to hand over this podium to our chair, Professor Chipinchi. Professor, all yours.
Well, our second session is on complex AVM radiosurgery. As we know, this is a difficult condition to treat, and usually they are either large or they are deep-seated, and they might be involving brain structures that have vital functions that cannot be sacrificed. They might be also involving deep venous drainage. Now, surgical excision usually is almost impossible without causing any serious consequences, including compromise of the vital neurological functions. Embolization might cause some mobility as well, and it might not be complete, and usually you require further treatment. Radiosurgery seems to be feasible as an alternative, but you require special programming and planning. Today we have Dr. Carolina Benjamin, who is going to present on the treatment of this complex AVM.
Thank you so much for that kind introduction, and thank you for having me here today. It's a pleasure to speak. So I'm Carolina Benjamin. I'm one of the cranial and skull-based and vascular surgeons at the University of Miami and Jackson Health System. And like the professor mentioned, you know, arteriovenous malformations they require complex management and a multidisciplinary team. It's actually a perfect segue from Dr. Raz's talk, which was excellent. I worked with Dr. Raz in New York where I did my training. And, you know, the amount of time we would spend together in the AngioSuite trying to understand these AVMs and trying to understand what we can do to manage these was really significant. It really does take a group of people. So I think that was a perfect segue to this. And the improvements in imaging has actually helped us be able to offer all sorts of managements. My disclosures are, I am a consultant to Electa, but otherwise not relevant for this talk. So I think it's very hard to give a talk about AVMs without sort of mentioning Aruba. I'm not going to spend too much time on this. But it is important to talk about the Aruba trial, which, as we all know, was initially published in 2013, cohort of 200 patients. And this was a trial that was designed to be with a 12-year follow-up period, looking at the primary end results of death and stroke. So important to sort of mention with Aruba is that the interventional arm was really any treatment that was deemed appropriate by the local Aruba investigator to achieve obliteration. Now, that doesn't mean that those that it did in fact achieve obliteration. It was just that the Aruba investigator said that he or she thought that the treatment modality would possibly achieve obliteration. So I think that's a nuance that's important to understand. As we all know, it was halted early because of the interim analysis, concluding that the group who underwent medical therapy alone resulted in less death and symptomatic stroke than the intervention group. So here on the left side, we have the 2013 analysis, and the average follow-up at that point was 2.75 years. And then we have, the final Aruba update, which was published in Neurology in Lancet Neurology in 2020. And if you look at that, the average follow-up was 4.2 years. And as we saw, this was a study that was planned to be of a 12-year follow-up study. And so, there are a lot of problems with this study, and I'll go into that a little bit, not too much, but essentially less than 20 of the patients received surgical resections of their AVM. So this was really just there are a lot of issues that allowed us to prevent us from being able to make good conclusions, right? So often, as we all know, some of the Aruba criticisms include the selection bias, a low number of grade 1 and 2 AVMs, lack of treatment arm standardization, low enrollment rate, and then, as I mentioned, inadequate follow-up to really capture the natural history of AVM and the efficacy of certain treatments, SRS, right? So some of that treatment you saw was 2.75 years, which, as I'll mention a little bit later, is shorter than the time period that it may take for SRS to have its efficacy. Adverse events included things just like headaches, so it was an overestimation of the treatment morbidity, and there was also a lack of subgroup analysis. So without spending too much time on Aruba, as we saw, this was, a limited study. And this really led to sort of inspired a series of different studies that were done from 2014 and beyond to try to look at whether or not this was really what the conclusions that we can make. And now the limitations of a lot of these studies was that they were retrospective and single center in nature. But as you see here, these are all patients who were Aruba eligible, large number of patients, and they tried to see, they actually included patients who underwent more surgical intervention. And what they concluded was that the treatment arm actually did not have increased complications compared to the observation arm, and the obliteration rates were high. With acceptable rates. In fact, complication rates were actually lower than the intervention arm for Aruba. So I think these studies that we, while everybody sort of talks about Aruba, these were really critical studies. And as we all know, that's really changed our mind about whether or not, treatment is warranted in these patients. Interestingly, so you want to think about a study that comes out like that. What was the impact of Aruba sort of on treatment? Even though, a study like that may have criticisms, and the neurosurgeons who are cerebrovascular neurosurgeons may understand those limitations, as a whole, it did impact other people's impressions of whether or not the AVMs should be treated. So for unruptured AVM, there was there's been a significant decrease in interventions post Aruba, so that's interesting. And then for ruptured AVMs, while there was no change in overall interventions, there was a significant increase in endovascular treatment, embolizations for AVMs. So there, even if Aruba had limitations, and even though there were many of these studies that I mentioned that came out afterwards, this did have an impact on sort of AVM care. What we see here is that there was a very clear, sharp decline in the peri-Aruba period. It was sort of, the AVM treatment was declining over time, but then as you see around 2014, 2015, you do see this sharp decline. And then for the first time in 2017, the annual rupture incidence actually surpassed annual intervention rate, which is bound to happen. If you're going to decrease your intervention, then the theory is that annual rupture rate would increase. One thing that we can take away from all this is that, again, the time frame that we're seeing that it takes for to see the effect of decreased intervention, there's about an 8-year lag time to see that impact. Now, radiosurgery has changed the ballgame a little bit because it has allowed us a different outlet and a different treatment modality that can sort of circumvent some of the risks that were concerns in the past. So our management options for AVM still remains observation, microsurgery, radiosurgery, embolization, or a combination of this. And today I'm going to focus mostly on radiosurgery, and in particular radiosurgery for some of these AVMs that are very complex. So what's the pathophysiology of radiosurgery on AVMs? Essentially, it leads to the inhibition of the Notch signaling pathway in rat models. The thought is that it leads to reduction in the nidus vessel size and thrombotic occlusion. So this was just, a study done in rats, but what you see activation of the caspase, and you see increase in the Notch signaling and some of the sort of distal ligands such as jagged and delta. That increases post radiosurgery, and the thought is that what it causes thrombotic occlusion of the nidus vessel as well as thickening of the vessels, and that way it shrinks the AVM over time. So that's sort of the pathophysiology, and that's what happened. That's what's happening on a biologic level. As you can imagine, and this is over 7 days in a rat model, but you can imagine this takes time. So one of the important things to realize is that radiosurgery for AVMs is something that's not going to happen overnight, and it does require a lag or a latency period. So what are some indications for radiosurgery? Deep AVMs that are not surgically accessible. You can do radiosurgery for small to medium volume AVMs, perhaps in eloquent locations. You want to reduce the other reasons to do radiosurgery is you want to reduce the surgical risk in these critical locations. And then perhaps if you have residual AVMs after prior management, and then also, and this is very important, patient selection for the larger symptomatic AVMs with no other options. And that's what I'm going to be really focusing on today. So what's the hemorrhage rate in patients with these high grade AVMs? Are we really justified in treating? So this is an interesting study here, and really shows this was out of the UCSF group, and it really shows that the annual rate of hemorrhage in this study happened to be higher than any other series. So we're obviously seeing a selection bias, right? This is an institution that's getting a tertiary center that's getting referred some of these inoperable or very difficult to manage AVMs. So we are inherently looking at a different population. It is a single center study. But what they found is that the initiation of the concerns or sort of the criticisms of doing radiosurgery, perhaps in multiple sessions for AVMs, is that you would get possible hemorrhage, not only in the latency period, but if you did staged treatments, then you have increased risk of hemorrhage because you're treating part of the AVM, causing that proliferation and vessel thrombosis in part of the AVM, thus leaving the other portion of the AVM sort of more fragile and more prone to hemorrhage. And what they found is actually the initiation of treatment did not appear to increase the rate of subsequent hemorrhage. And again, because the hemorrhage rate before treatment, is reaching high levels, the treatment for these lesions may in fact be warranted to try to sort of circumvent the natural history over time. This is actually out of Dr. Raza's group in New York. And this is just an interesting look at, can you predict which AVMs are going to have good response? And what I think is interesting here is that it's really looking at and again, this goes just in line with his talk, but it looks at some of this dynamic imaging to see whether we can predict obliteration. And you can see here there was a significant difference in flow. So if you have certain, and this was a multivariate study compared, and high flow was sort of the comparison group, and you can see that there is a significant difference in AVM obliteration based on flow, with the ones having low flow being able to be obliterated in shorter periods of time than the ones with high flow. So I think looking at some of this more precise and dynamic imaging gives us more insight as to which AVMs are going to obliterate and which time frame. And I think that's important to sort of quantify the risk to our patients and help guide our patients when we're talking to them in the clinic about treatment of these AVMs. So looking just back at some AVM radiosurgery, I'm going to talk about the Pittsburgh data. I trained with Doug Hunziolka, so a lot of this data comes from him. And he has a vast experience in AVM radiosurgery. So if you look at their series, they had a total of 800 patients, which is a significant number. And 46 of those patients underwent stage gamma knife for large AVMs. And then 105 patients had repeat gamma knife for failed AVMs. A lot of patients, about half of the patients presented with a hemorrhage. Other symptoms that were common are seizures, headaches, focal neurologic deficits can happen, and then incidentally found perhaps due to trauma or other forms of imaging. Patients who had prior embolization, a few patients had prior embolization, again, seeing that effect of the fact that embolization did go up after the Aruba period. And then previous surgery with residual AVM was about 10 or 11% of the patients in this cohort. The locations, as you see here, sort of a variety of things. Some of them are going to be more superficial and more accessible surgically, some of them deeper and more eloquent in nature. And you can see here, AVM volume greater than 10 mLs, 85 patients. So there was a good number of patients that had what we consider sort of high volume, difficult to treat AVMs. Again, and we'll go into dosing a little bit more, but median margin dose 20 grays. We need to hit these hard in order to have good efficacy. And there are 89 patients with the coexistence of aneurysm. Venous varices are common in these patients. And then the median target volume was about 5 cc's or just below 5 cc's. So what this study found is that the obliteration rate really falls sharply below 16 gray margin dose. So you can see here the percent obliteration and the prescription dose here on the side. And below 16, it really does drop pretty precipitously. So it's important that when you're treating these, you have to get it to a volume where you're able to push the dose past 16. And that's where the staging comes in. And increase from 20 to 25 grays can really continue to increase the obliteration from 90 to 98%. So that's pretty significant, but you're getting to high doses, and doses in the 20s are going to be difficult for these large volume AVMs. So the time to obliteration was, the median time to total obliteration is about 36 months. So again, this is important, right? So that Aruba study it was 2.75 years. So it's important to know that this is going to take time, and this is because it has to have a radiobiological effect onto the vessel wall before we can see changes in the dynamic flow. The bleeding rate from AVM, you can see here at 6 months, about 2, and goes up to 10 years, goes to about 8. And increases. So months after radiosurgery is here in probability of bleeding. So there is a risk of bleeding in that latency period. And I'll go into that a little bit further as well. So what did we find from this, the Pittsburgh, what did this Pittsburgh study sort of tell us? Essentially, younger age was associated with a lower bleeding risk. Higher margin dose was associated with higher total obliteration rate and lower bleeding risk after gamma knife. Presence of a varix and number of prior bleeds was associated with higher bleeding after gamma knife, and prior embolization was associated with lower total obliteration rate. So the important thing about this is when you're talking about radiosurgery for complex AVMs, there is a threefold problem. Number one, you want to talk about, does it work, right? Are we getting good obliteration rates? And I think, pushing the dose past 16 grays allows us to get better obliteration rates. Number two, all right, now you've given it enough of a dose to obliterate it over, that 36-month period. What's your hemorrhage risk in that latency period or post radiosurgery? And I think that's another concerning factor, and we can control some of it, and we can't control some of it. So there is going to be a bleeding risk in that latency period, and it's important to counsel patients about that. And then finally, what are going to be the adverse radiation effects? So again, this was a single study. Embolization does seem to significantly impact obliteration rates. And that has to do, with probably just scatter and artifact and imaging, which that's actually improved over time. But previously, there was significant ability to sort of identify the nidus and target when there was a lot of embolization material obscuring our imaging. And then if you had prior bleeds, that also significantly impacted obliteration rates. This again is dose response. So again, less than 16 gray, you have that precipitous fall in obliteration rates. Greater than 20 grays, you have that sort of boost from 90 to 98%, even if you're getting above 20 to 25. And then somewhere in between are these doses that you're working with, 16 to 20 grays. You really want to work in that sort of zone. And that is why, we talk about staged radiosurgery for some of these really complex and large ones, because we really want to work in this zone. And for us to be able to do that, the only way to do that is to reduce the volume. So again, AVMs that were greater than 8 cc's in volume, you can see that they had lower obliteration rates than AVMs that were less than 4 cc's in volume. So these complex sometimes hemispheric AVM, multi-compartment AVMs, grade 4, Splesser-Martin grade 4 and 5 AVMs, they'll often be greater than 10 cc's. And as you see, you're going to really impact your ability to obliterate the AVM with radiosurgery. And so this concept of stage radiosurgery really allows us to decrease the volume in order for us to be able to push the dose. Again, based off of location, as we had mentioned previously, some of the brainstem AVMs can be more difficult to treat, whereas other supratentorial or cerebellar AVMs tend to do a little bit better. And then this is just based off of Pollock-Flickinger score, with a score greater than 2 doing worse. So that was a single center study, right? And as we all know, those have limitations. So this is a nice multi-center study looking at patients who were likely to have a good response post radiosurgery. So you can see here that patients with a prior hemorrhage, again, were less likely to have deep-seated lesions and nidus with a component of deep venous drainage. Most importantly, deep AVM location and an AVM-associated aneurysm were predictors of post-SRS hemorrhage. So if we know that, obviously you can't change the location, so that's just more of a counseling thing for patients. But in terms of AVM-associated aneurysm, this study sort of suggests that we should be treating those ahead of time. In order to prevent, or subsequently after the radiosurgery, but before the latency period, in order to prevent hemorrhage, try to decrease the risk of hemorrhage. Importantly, and I think this is just something we see throughout all the studies pretty consistently, is that the margin dose was a negative independent predictor. So if you have a lower margin dose, you're going to have more difficulty obliterating the AVMs. So this conclusion, this is the pre-SRS hemorrhage and the post-SRS hemorrhage, and you can see that for all the Spetzler-Martin grades, it was significantly different, that the hemorrhage rates were significantly different and improved after SRS. So I think this is a nicely done multi-center study that shows us that SRS for AVMs does reduce subsequent risk of hemorrhage. And this is, again, importantly driven by obliteration. So just because you treat the AVM does not mean it will respond. And so it is important to get that follow-up. And the recommendation really is to do an angiogram at 3 years. I tend to follow my patients with MRIs, or if I'm concerned, MRAs or other vascular imaging. I don't do a formal angiogram until about the 3-year period. And then I take a look at sort of obliteration rate. So this, again, reduced hemorrhage risk is only going to happen if you actually get that obliteration. Deep-seated AVMs are prone to hemorrhage during the latency period. That's important for patients to know that there's going to be a price to pay, and some of the patients are at higher risk. And then again, as I mentioned, occlusion of AVM-associated aneurysms, at least in this multi-center study, is indicated to decrease the hemorrhage risk in the latency period. And this was another study, again, looking at hemorrhage risk and obliteration rates. And actually, you can see that volume had a significant impact in this study. So we'll talk a little bit more about volume and how to get, why is that's important. Again, if we're talking about pushing the dose to higher doses, and you cannot do that with volume, with high volume AVMs, because then your V12 or the amount of brain that is going to get a dose of 12 grays or greater, that's going to increase significantly with higher volumes. So if your V12 increases significant with higher volumes, you're putting your patients at risk for radiation necrosis. So the only way to sort of circumvent that is by decreasing the volumes. And so there's the staging sort of, there are two concepts for staging when this was sort of brought about. First was dose staging, which is treating the entire volume with repeated low SRS doses. Sort of that concept sort of allows for recovery in theory in between sessions. And then the other staging, which is what we adopt and sort of use now, is volume staging, which is an attempt to provide a potential therapeutic dose to two separate volumes of the AVM. So you essentially, depending on the size of the AVM, you separate it into smaller volumes, usually 2 or 3, can be up to 4. Nothing says that it can't, but you essentially treat it as separate entities, and you give each time that you treat one of those separated volumes, you give a potential therapeutic dose. You really push the dose and measure. You're able to measure the volume of that you create, and then push your dose accordingly. So again, we don't really use this. I don't really use this dose staging, volume staging. There tends to be plenty of data to support, and these are some of the papers to support volume staging as opposed to dose staging. These are some of the studies Looking, just summarizing some of these findings, if you look here, these are really high volume AVMs that we're talking about, right? So this is in cubic centimeters, some really high volume AVMs. And as you can see, the higher volume you get, you're going to have to decrease your dosing unless you separate it into staging. And you can see here, you're able to push it past that 16 gray level if you're able to do it in multi-stage. Important to know that the obliteration rates are not perfect. This is not a home run, and that's important for patients to know going in. You can get good obliteration rates. There is a latency period, and look at this. The adverse effects, it can be high. So there's a price to pay, and I'll talk about some of those adverse effects in just a bit here. This is the whole paradigm about volume staging is exactly this. It allows you to increase your dose greater than 17 grays. This is another study out of the San Francisco group looking at this. Increase the dose past 17 seemed to have a significant difference. AVM volume had a significant difference in complete obliteration. So the higher the volumes, the more difficult it is to treat. And then compact nidus also had a significant difference. So again, as you can imagine, if you have a compact nidus, you're more able to sort of you're more able to get your dose in a smaller area, as opposed to trying to chase small little feeding arteries, and that's where the compact nidus becomes important. They essentially prospectively decrease the treatment volume per stage to less than 8 to 10 millimeters. And then they shortened the interval from 6 months to 3 to 4 months. And they try to push the doses past 17 grays. And then they compare their findings in the era 1 and era 2. And what they found is in the era where they did those things to try to optimize the treatment of the complex AVMs, they got better obliteration rates and less toxicity, less complications. So again, here is just showing that the 17 gray led to it. Let me see here. The 17 gray, if you push that dose, your obliteration rate is going to happen faster and better. And then also in the era 2, where they adopted all those changes by decreasing the volume, they also tended to have their time to cure tended to improve, and their outcomes were better with less complication rates. So that was one single center. That was the sort of the UCSF. This is the Pittsburgh data looking at staged radiosurgery. You can see here again, medium target volume. The first gamma knife is about 11 cc's, second gamma knife is about 10 cc's. So some of these AVMs are very large, ideally decreasing it to 8 to 10 cc's, but again, you can have a little bit higher than that sometimes. And then median interval is 5 months. That ranges in much of the literature between 3 to 4 to 6. It can be longer depending on how the patient's doing, right? So sometimes there are patient factors that prevent you from being able to do the second stage right away. And again, median margin dose, look at that 16 gray period, and the UCSF study was 17 grays. So 3 patients had symptomatic adverse reactions after staged radiosurgery. And then 2 patients had it after a 3rd stage. So number of bleeds between the gamma knife, the first gamma knife and the second stage was 1 patient. Number of bleeds between the second and the 3rd stage were 8 patients. So there are going to be patients that are going to be bleeding in that latency period. So that's important to sort of know. And time to obliteration, you can see here, it takes time. So again, most people were not really getting angiograms till about that 3-year period. At that 3-year period, if you still see, it really depends on the response of the AVM, what you do at that point. You might want to just hold off, if it looks like it's almost obliterated, that may, you talk to the patient about doing a repeat procedure at that time. If you have reason to believe that, this is near complete, you can also choose to wait another year. There's still radiobiological effects going on in that the 3rd to 4th year. So you can wait another year and repeat an angiogram versus talking to the patient about another repeat gamma knife procedure. And the median time to obliteration here for the repeat gamma knife is about 115 months. So again, these are patients you're going to be seeing consistently, following with MRIs. You're going to be getting that angiogram at about 3 years. Sometimes you delay that to about 4 years, and then talk about repeating a procedure at that point. So higher margin doses were associated with higher total obliteration rate, and the larger number of prior bleeding was associated with higher bleeding, as we've seen. And that was sort of present in the univariate analysis as well as multivariate analysis. So again, these are so the staging proved to be efficacious both for single center studies. What about the multi-center study? So this is part of the IRRF group, and this is a nice international group that sort of combined this multi-center study, and they found similar findings, which the margin dose tended to be important, greater than 17 in terms of obliteration rates and time, total time to obliteration, as well as probability of total obliteration. And then number of prior hemorrhages also tended to affect obliteration rates, with people having had prior hemorrhages having worse obliteration rates. So here's sort of an example, and I'll go through some examples in just a bit here too, but you can see you essentially create two portions, and you divide the you divide the AVM into different segments, and you treat each one as its own separate entity, and you give each one a dose that's high enough to obliterate on its own. So you sort of think of it as two separate treatments in the same patient. The nice thing about Gamma Plan is obviously you're able to see what you've done in your previous treatment, and you don't want the treatments to overlap significantly. Always checking your V12 to make sure that you're, the amount that that your V12 is not getting too much higher, and that you're going to prevent any adverse reactions. This study just tried to sort of identify factors that influenced early obliteration, which they consider to be less than 18 months. And some of the factors that they found in the multivariate analysis was no previous radiotherapy, history of prior surgery, smaller nidus, and then nidus location, and doses greater than 24 grays. Those are factors that influenced early obliteration. So, again, this helps us counsel our patients as to, who can expect to have an obliteration rate less than 18 months. And we'll talk about whether or not that it has an impact on adverse reactions, and I actually do think it does. But early obliteration was common in patients whose AVMs are smaller, frontal lobe, basal ganglia, or cerebellum, patients who had deep venous drainage and received a margin dose greater than 24 grays. So those are ways to sort of risk stratify our patients. Now let's go to adverse reaction effects, because that becomes significant. You can see here in this photo, this is a previous AVM, and you see this almost like a tumor, and it acts, just in that way. It can act similarly to a tumor. And this, again, looking back at the Pittsburgh data, they had 46 patients with adverse reactions after gamma knife radiosurgery. And it's really related to the dose, the volume, and the location. Location, target dose, and target volume being very significant. And then, the higher grade AVMs being, also more difficult to manage in terms of getting more adverse reactions. So you can see that the risk of AVM complications is going to be related to the dose of V12, like I mentioned to you, and the 12 gray volume can be used to predict that risk by location. This is important. This is where our physics team comes in and helps us mitigate our dose and make sure that we're doing this safely. You can see that the brainstem, pons, midbrain AVMs, your risk of having some adverse radiation effect is going to be higher. Now, these are just locations that don't tolerate a high dose of radiation. And that's, some of the more forgiving areas, as you would expect, in the frontal lobe or even intraventricular. But as you get towards basal ganglia, thalamus, pons, midbrain, that can become quite tricky. Other late complications are cyst formation, and that can happen in a small number of patients. Times of prior bleeding was associated with a higher rate of developing late cyst formation. Now that whether that has to do with the fact that prior bleeds may lead to some cystic change pre SRS, that could be the case here, but that was significant, at least in the Pittsburgh series. Here's a hot off the press. This is actually out of Dr. Raz's group in New York as well. And they're trying to, we're talking about the fact that we have adverse radiation effects if you have higher doses, higher volumes, and, in certain locations. Can we quantify that? Is there a way to sort of identify and sort of measure the flow in a way to tell us which patient or which AVMs are going to have higher risk of adverse reactions after radiosurgery? And this is some of their data that was presented just now at the at the AANS meeting in LA. Essentially, they're using dynamic imaging during angiography to look at transit times and vessel diameters. And they're trying to use that as predictors of adverse radiation effect and edema following SRS. It is important to know that, while the edema, we do see this T2 signal change, and you can see some of these photos here, you see T2 signal change in the brain. That doesn't necessarily correlate to a neurologic deficit, but it often can, and it can lead to seizures, neurologic deficit, headaches, hemorrhage. And so it's important to sort of differentiate between a radiographic effect, which we're seeing pretty frequently, and then a true adverse reaction where the patient requires corticosteroid treatment and possibly even Avastin for radiation necrosis effects, and for example, in a patient like this. So I think this is very promising. I think it'll be tremendously useful to try to, be able to look at the angiography pre-gamma knife and sort of calculate the ratio and the transit times and then identify which patients are at higher risk for adverse radiation effects. I'm just going to finish up by going through a few cases. This is and sort of illustrate some of the things I talked about. This is a 48-year-old with right-handed flight attendant. He presented with complex partial seizures and was found to have this AVM here, as you see it. This AVM is a tricky one. While it's not tremendously large in volume, it's sort of diffuse in its nidus. It has a little bit of a compact nidus here, but then you see it a lot of hypervascularization and small vessels throughout. And here are the coronal images. Here's the angiogram. We can see here being fed by both the ACA and the NCA vessels. We see this large superficial early journey vein. And I think, as Dr. Raz mentioned, the more we know, the better. And so I tend to get as much imaging as I can to sort of make this as safe as possible. He did present with motor seizures, which makes sense based on the location of this AVM. And this is a DTI showing us the corticospinal tracts just medial to a portion of that AVM. You don't even see motor strip here, but this is essentially where the motor strip is. So, I'm concerned that if this person has an adverse radiation effect, they're going to have significant impairment, possibly be completely weak on the contralateral side. So this is concerning, and I use this to guide, to sort of my conversation with the patient in the office. So he underwent a 2-stage approach. The first stage, 6 cc's given 18 grays at the 50% isodose. And you can see here, and here's another thing that I like to think about when I do these is what should you treat first? My preference is if, you have AVMs often have this cone shaped here. I tend to treat the deeper locations first, because I think that is going to, it provides me a sense of safety that perhaps what could be the more dangerous area to in terms of a hemorrhage risk. If I treat that first, then I'm a little bit safer. I've protected the patient a little bit. He subsequently underwent stage 2, which was just 3.5 cc's, got 18 grays at the 50% isodose, limited a little bit. We tried to push the dose a little bit, but the V12 was getting a little bit higher. And you can see here some nice thin cut T2 space images that we use also for the planning. We use both the post-contrast MPRH as well as the T2 space. And you can see here that these are 2 separate entities. And this was pushed to an 18 gray. So 4 months post-op, you get this significant amount of edema. So the patient is not doing well. He is in fact having worsening seizures. He's now on multiple AEDs. He presented with seizures, right? So I did warn him of the risk of having worsening seizures, but he in fact developed worsening seizures and was significantly weak. And so this is a problem, right? Treatment with corticosteroids for several months, not doing well, sort of in and out of the hospital. You can see at 7 months post SRS, he's having this almost, what we see in radiation necrosis, this very classic appearance, sort of that wispy sort of enhancement. Interestingly, at 9 months post-op, you don't really see much a filling of the AVM at all. Now, this is just an this is an MRA. We have not gotten his angiogram yet, but this is quite interesting because clearly this patient is one of the early responders, but there's a price to pay. He went through a significant period, a period of about 4 or 5 months where it was dicey there. You can see here at 1 year post-op, this is already significantly involuted. Very manageable. He's no longer symptomatic, off of corticosteroids, never required Avastin, but this is, a two-stage approach. A patient who presented with symptoms was still treated with this two-stage approach and had a price to pay. Now, I think, the 3-year angiogram is going to show a nice obliteration rate, but again, a significant price to pay. Another case here, a 32-year-old presented with a previous hemorrhage, was shunted at an outside institution. This was her original AVM. I mean, multi-compartment, deep in venous drainage. This patient was severely debilitated, and young patient, 32. So they, sent to be by my partner Jacques Morcos. Obviously an inoperable location, and he says, "Can you radiate this?" And so, again, I do my DTI imaging. You can see some of the cortical spinal fibers really in significant locations. I tend to do corticospinal, and then this is arcuate here. So I just try to get as much information as possible to be able to tell the patients, hey, what risk are you at, and how can I keep you the safest? And so I did this 2 stages again. This was one that you could argue that could have been 3-staged as well, but the stage 1 had 11 cc's. I dropped the dose to 16, 50% isodose. This patient also, important to know, the patient was significantly debilitated neurologically when we started the treatment. And that concerns me because that tells me that there's probably a sick brain that I'm dealing with. And that concerns me for a post-treatment hemorrhage. So I'm a little bit cautious in those patients. This volume here was treated first, 11 cc's. Then I went back and treated the second stage, which ended up being 17 cc's. This is the blue is the previous treatment, and then the yellow here again, going back to the previous image, I did treat this sort of deeper area first. And then you can see the previous treatment. I've treated this more superior portion second with 15 grays at the 50% isodose. So there's been, this is 7 months post SRS. There's been significant involution. This again, only on MR imaging. She had a little bit of edema. She had this pre-treatment and that wasn't concerning me too much. But at 19 months post-op, I'm very happy with what I'm seeing on the MRI, but the patient got significant edema and is paying a price now. She's symptomatically went through a period again of being in and out of the hospital, requiring corticosteroids, never went to Avastin, although I did offer it to this patient. And this is a patient, again, complex AVM, still treated it multi-stage and had a high price to pay. She's now actually significantly improved. I think, again, the AVM is doing very well from the whatever dynamic changes are happening are showing it's having good effect. And we'll get that 3-year formal angiogram to show the final result. And she has now improvement both clinically and radiographically. And this last one, I don't have the post-op imaging for this one yet, but I wanted to show this case just because of the location of this AVM. Again, sent to be by my partner, not operable case here. You can see this large AVM, a lot of the Sylvian vessels are involved. Importantly, I got him some functional MRI with speech mapping, and what allowed me to treat this AVM, if you look at it, although he's right-handed, his speech has really, all the critical functions of his speech had really sort of gone to the contralateral side. So, and we know that can happen, as AVMs are lesions that have been there for a long time or possibly congenital. And so this patient got treated with 2 stages. I did the superior portion here first. 17 grays, 8 cc total. And then the second portion here, 17 grays, again, 11 cc's. So these are high volume AVMs treated in 2 stages. And, that person has not come for their follow-up imaging yet. This was recent that we've done. So this was an important one because, the functional MRI really allowed me a lot more safety in treating this in this location of the angular gyrus where I was concerned for his speech on the left side. And he presented with significant complications from seizures that required multiple hospitalizations and renal failure. So this was a patient that, clearly needed treatment. So just in conclusion, AVM radiosurgery is an effective management option for properly selected patients. Staged volumetric radiosurgery increases options for treatments. Temporary adverse radiation effects can occur. T2 imaging or flare imaging changes are more common. They sometimes can correlate with neurologic deficit and don't always. Studies quantifying the flow may help stratify risk for adverse radiation effects. And I think that's sort of where our future studies are going to go. So thank you so much for having me today. That's my contact. Please feel free to reach out to me with any questions.
Well, thank you very much, Dr. Karina, for a comprehensive presentation of radiosurgical treatment for complex AVM. And as we can see from your presentation that many times rate of obliteration is related to the volume, the dose, and also the location. And so are the adverse, the prediction for the adverse reaction. I'm actually quite impressed by cases that were done by you. I mean, we have to go through the, the period when patients have to suffer quite a bit of symptoms after even the stage AVM treatment. I have one question for the second case. Why the dose, the second stage for the second case, the dose was lowered to 15 gray? Is there the factor that limit the dose to be lowered to be 15 gray instead of 16 or?
Yeah, so that's the one that I mentioned. We always look at our V12. So this was the one where, our V12, because of the volume of the AVM was so high, our V12 happened to be a little bit higher. And what I also am concerned about when the patient's initial neurologic presentation, she was very debilitated, when I treated her, which meant to me that she had a really sick brain or a sick hemisphere. And I get a little bit concerned about sort of pushing, the doses, because I think patients who have a deficit in the hemisphere, a functional deficit to begin with, are going to tolerate a radiation effect a lot less than patients who are starting out neurologically well. We know that they have not undergone a hemorrhage. They have an otherwise healthy brain. I think that those patients tend to tolerate the radiation a lot better. So if they have a radiation effect, they can usually get through. But I think, her ability to get through a radiation, an adverse radiation effect is a lot lower. So that's why I did a little bit of a lower dose and the total volume was just a high volume AVM. So, I think it's had a good response so far. We'll see whether or not that leads to complete obliteration. That's also a patient that I counseled the family as well as her, that this may be somebody that at 3 or 4 years, we see that there's a little bit of a residual and we need to go in. At that point, the AVM is much smaller and it's much more manageable to do even a third stage if necessary. It's also spaced out in time sufficiently, with the 3 or 4 year gap, that it's a lot safer to then re-irradiate at a smaller dose.
Yes. So you don't have any experience on dose stage, the means fractionation. I have the same feeling as well. Actually, I don't really believe that it might work. Although I tried on one patient some years ago, and surprisingly, that patient responded. It was a large AVM at the left-sided temporal lobe. But that's one off on me.
Yeah. I think the data, some of those studies that I showed you, I think the data really is supporting sort of volume staging rather than dose staging at this point. And I think from a biological standpoint, I think it makes sense that if you're going to have a stronger biological effect, treating these AVMs as the different compartments as separate entities makes more radiobiological sense.
Yes. Is there any questions from the audience?
Well, so far we have none, but I would just like to ask Professor one question, that you showed us that doses around less than 16 decreases the obliteration rates, and about 20 significantly increases the obliteration rate. So just I would like to, please pardon my ignorance, I would like to ask, what are the factors that narrow down to choose a dose which are appropriate for lesion?
So essentially, I take everything into consideration. Importantly, you have to take into consideration location, right? That we showed that locations such as, thalamus, brainstem, they're not going to tolerate, right? So if that's, you're gonna decrease your dose based off of location. If you have a really large volume AVM and you're doing your second or even your third treatment, you have to look at V12, cumulative V12, right? Because you're doing these maybe 2 or 3 months apart. So your V12 can sometimes be the limiting factor. It's a little bit of experience. Can you hear me?
Yes, we can.
I'm sorry about that.
We can.
And then it's a little bit of experience too, right? Like I mentioned, if the patient is starting out with neurological dysfunction, I tend to take that into consideration and limit pushing my dose too much. Prior risks of hemorrhage have lower obliteration rates, so it's kind of a balancing act, right? Because the prior risk, many patients with prior hemorrhages do have dysfunction, which would make me sort of think maybe I need to lower the dose a bit. At the same time, people with prior bleeds also have more difficulty with obliteration, right? They have less obliteration rates. And so then I try to push it. It's really just more of, playing both sides in terms of deficits and speaking with the patient and making them very sort of aware of what the risks are and what their goals are in treatment, right? You have to take the risk profile of each patient. I think these are cases that are very particular. I tend to share them with my colleagues. Oftentimes, if I'm doing one of these cases, I'll outline what I'm going to treat for that compartment. And I oftentimes will send it to some of my experienced colleagues, UVA, Doug Konziolka, people, and we sort of have this lively discussion. And the radiation oncologists and the medical physicists are a very important part of that discussion as well.
Thank you very much. Just another question to the continuation. Are the doses any different for children than adults?
Yeah, so pediatric AVMs are a little bit tricky. The problem with pediatric patients is oftentimes you get that neovascularization, which you may not necessarily get in adults. The obliteration rates tend to improve, but because they have that increased risk of neovascularization, you have to increase the dose accordingly in order to prevent hemorrhage rates afterwards.
Thank you very much. Yes, Joey Sam has joined us. He would like to ask something. Joe?
Yes, thank you, Dr. Raja. Thank you, Professor Carolina, for fantastic lecture. It was very informative. I would like to ask a question about AVM embolization to reduce the size. I think there are some studies that says that embolization actually reduces the obliteration rates, and some says that it does not. So what is your opinion on this instead of a volume staged SRS?
Yeah, so I do think that prior embolization leads to more difficult. I think that what happens with prior embolization is that it makes it more difficult for us to sort of identify what the actual target is. And not always, but depending on the amount of embolization, you can be limited and you can miss part of the nidus, right? So if you miss part of the nidus because your view is obstructed by the previous embolization material, then you're setting up a potential area that can lead to future recurrence. So I think where the embolization comes in is really our visualization. Now, I did mention, as Raj mentioned, we do have better imaging techniques, and that's certainly sort of circumvented that challenge, but I don't think it's perfect. And so I think if, embolization is a great technique, if you're doing like a preoperative embolization, I think it can be very helpful to make the surgery faster, less blood loss and everything. But from a radiosurgery perspective, I don't see an advantage. I do believe, and I do send my patients with aneurysms that are flow related to be treated.
There is a question from Dr. Professor Zamsuri from Malaysia. He's asking whether, have you seen any adverse side effect at sites away from treatment for cases of volume stage? AVM.
So that's interesting. I have not seen different sites, but I have seen distant in time relationship. For example, I've seen obliterated AVMs that then subsequently, in a delayed fashion, you have almost like you have a hemorrhage. And then you find to have this almost cystic degeneration. And, we actually wrote a series of these when I was in New York. These patients would come after a complete obliteration. They were doing great. The imaging looked great. And then they would have a hemorrhage. And then you take this out in surgery, and it's almost like a cystic degeneration of the AVM in a distant time period. I have not seen it in a distant location.
Right, thank you. Dr. Dilshad, would you like to ask anything?
Yes, thank you so much for a great presentation, Professor Carolina. I wanted to ask you, what is the rate of your complications as a post-radiosurgery hemorrhage? What is the percentage of these kind of complications you have experienced?
Yeah, so I would say, I always tell people depending on the size, anywhere between 5 to 10% risk of some sort of adverse radiation effect and other bleeding complications. I also, I tend to not use a single sort of number because people get really fixated on the number, especially here. I really almost try to create a patient specific risk, and I focus more on telling patients low risk, medium risk, high risk, as opposed to telling them, this is your percentage risk of this, because then they'll come back to you and they'll be, well, you said it was this. So I feel patients who have this are very well informed. And what they really want to know is, what are the chances you're going to fix me over time? And, am I going to have some problem? I think it is really important to warn them of, that they may go through this period where they have an adverse reaction and you're treating them with corticosteroids. I've only used Avastin very sparingly, but I have had to use Avastin in a patient, especially in a patient with difficult locations in the thalamus and brainstem. But I do warn people of the possibility of both prolonged corticosteroid, prolonged AED, and possibility of Avastin use.
Thank you.
Thank you very much. If there are no further questions, we can take the final remarks from Professor Chipinji.
Well, I think it has been a good experience to listen to the very comprehensive presentation from Dr. Carolina Benjamin about the complex AVM treatment from the radiosurgical aspect. I think it's still evolving. So far, actually, at least we have seen good results for cases that are treated with volume stage treatment with doses above 16 or 17 gray. And we have yet to see further results coming out. And at least there's something there to offer instead of, previously when this has not been introduced, then actually there's patients have been facing quite serious consequences with no alternatives. I think, thank you very much. Actually, I do enjoy the talks.
Thank you very much. I think with that we can wind this session up, and I would like to close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both speakers of today, Professor Eitan Raz and Dr. Carolina Benjamin, as well as the chairs, Professor Naoto Kimura and Professor Chipinji, for the time and support for the ACNS webinars. A special thanks to our my co-host Dr. Libun Singh for joining me today, and also to our Vice President Professor Shubin, who has broadcasted this webinar on the WeChat channel. And as I mentioned earlier, there are around 430 people who have joined us live from across the globe on all 3 channels. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.